today we're going to talk about alterations in cellular regulation, specifically leukemia and sickle cell disease. You guys have covered this in class, so it's kind of going to be like a quick review, just kind of hit some highlights that you might see on your next test. Student learning outcomes for this lesson, we're going to describe the clinical manifestations of leukemia, design a nursing care plan for a patient receiving leukemia, identify 3 triggers that can trigger a sickle cell crisis, and prioritize the care needs for a patient presenting with a sickle cell crisis. So we'll jump straight into leukemia. So leukemia is a cancer of the early blood-forming cells, specifically the white blood cells most of the time. It affects the tissues of the bone marrow, the lymph system, and the spleen. And this results in an accumulation of dysfunctional cells. So this accumulation is due to an alteration in cellular regulation. Causes of leukemia, there is no known cause. It's thought to be a result of a combination of genetic and environmental influences. So these are just some influences that we do know about. I won't read through all of them, but just a combination of both genetic and these influences can result in leukemia. There's 4 main types of leukemia that you'll learn about. Leukemias can be acute or chronic and originate in either the myeloid or the lymphoid cells. So we'll just go a little bit deeper to compare those. Acute leukemias, they originate in the immature hematopoietic cells. So hematopoietic cells are the cells that form mature cells. So acute is in the immature hematopoietic cells, whereas chronic forms in the mature cells. Acute is fast growing and the symptoms do appear early and progress rapidly, so we want to get treatment rapidly as well. Whereas chronic is more slow growing and the symptoms have a more gradual onset. So the patient may have leukemia for years, not present with any symptoms until later on in their disease. Acute leukemia creates a large number of abnormal white cells that don't function properly, whereas chronic, since it originates in the mature cells, causes the white blood cells to function less effectively, but they do appear mature. When we look at myeloid versus lymphoid leukemia, the myeloid cells are bone marrow cells. So this is your red blood cells, neutrophil, eosinophils, basophils, monocytes, and platelets. Whereas the lymphoid cells are your lymphatic system cells. So these are the cells that are known for our immune system. They're going to fight our infections. It's the T lymphocytes, B lymphocytes, and natural killer cells. So this is just that same chart. Like I said, there's these 4 that are the common ones that you'll see. We'll talk a little bit more about them. So acute myeloid leukemia is also known as AML. That represents about 1/3 of all leukemias. Since it is acute, its onset is abrupt and dramatic. It causes the bone marrow to overproduce abnormal white blood cells. So remember, with acute, it's immature cells. So this is an overproduction of abnormal cells. With acute lymphoid leukemia, this is the most common type in children. It causes the bone marrow to produce too many abnormal lymphocytes, and CNS manifestations can be common in this type. So you may see the student, or the child present with cranial nerve dysfunction. They might have increased intracranial pressure, that kind of thing. Chronic myeloid leukemia, this begins in the blood-forming cells of the bone marrow, which is the chronic phase. So this phase can last for years. The patient will be asymptomatic until they reach the blastic phase, which is where it progresses into the blood and infiltrates the liver and the spleen, and this is where you want to start aggressive treatment. There's an increased incidence with age, particularly over the age of 65. With chronic lymphoid leukemia, so this is the most common leukemia in adults. It is characterized by the production and accumulation of mature appearing lymphocytes. So what that means is that these lymphocytes, they appear like they're mature and that they'll fight your infections, but in reality, they don't function properly to fight that infection. They will infiltrate the bone marrow, spleen, and liver, and many patients don't need treatment early on. Just like CML, it may be years before before symptoms do appear. So common symptoms in all types. Leukemia symptoms do present very similarly because it is related to your white blood cells, red blood cells, and platelets and alterations in those. So common symptoms are related to that. If you think about a patient who has decreased red blood cells, they may be fatigued, weakness, have some shortness of breath. That's related to that anemia. In a patient with decreased platelets, they're prone to bleeding, and that's due to the thrombocytopenia that they're experiencing. Patients with decreased white blood cells will have a fever, frequent infections. That is due to the neutropenia that they're having. Patients may also present with weight loss, night sweats, bone and abdominal pain, abdominal fullness, and swollen lymph nodes. And I do want to point out that these last three here, these are due to a buildup of the leukemic cells in that area. So they may be having pain or pressure because there's a buildup of those cells. And specifically with the lymph nodes, we're concerned that a buildup of cells in the lymph nodes can press against nerves and cause pain and sometimes even paralysis. So we tell the different types of leukemia apart by blood tests and bone marrow studies. The blood test would be a CBC, which would reveal red blood cell, white blood cell, and platelet counts. There are also methods to identify the cell types in the stage of development and genetic mutations. And occasionally they will do chromosome tests. This is the hallmark diagnostic for CML, the Philadelphia chromosome. Treatment for leukemia, chemotherapy is the mainstay of treatment. Along with chemotherapy, the patient may receive radiation. So this can be total body to prepare for a stem cell transplant, or it can be to certain areas that have an accumulation of those leukemic cells. The patient may also be on corticosteroids. Now when we're referring to the stem cell transplant, there are a couple of different options for where the patient can get that transplant from. They can get it from an HLA-matched sibling, an HLA half-matched relative, volunteer donor, which would be your allogenic transplants, or a identical twin, which would be your syngenic transplants. You also need to consider supportive therapy. So this is therapy to deal with those side effects of chemotherapy that they may be having or the side effects from leukemia. So we'll talk a lot about the considerations. When we're caring for a patient undergoing treatment for leukemia, we need to think about the side effects of chemo. So those common side effects such as hair loss, mouth sores, loss of appetite, nausea, vomiting, those that are listed here, we need to think about how can we minimize these side effects. So provide those patients with resources, whether it's community sources for support or social work, somebody to come out to their house, provide them with resources, do regular mouth care on them because they have those mouth sores. Encourage them to have a diet full of protein and calories so that they can maintain their nutrition. And have them on a bowel regimen to help prevent that diarrhea, constipation, and keep them regular. Other considerations do relate to the anemia, thrombocytopenia, and neutropenia. So we want to make sure that an anemic patient gets plenty of rest periods. We provide them with oxygen as needed, and if they need a transplant, that we get that for them. With thrombocytopenia, that patient is at an increased risk for bleeding. Look for signs of bleeding such as petechiae, echinosis, nosebleeds, hypotension, and tachycardia. And an important teaching point for these patients is when they go home, be careful when they're shaving. If they cut themselves while they're shaving, they're at an increased risk for bleeding. As well as if they bump against this desk, they're gonna bruise more than we would. So just little things like that people might not realize that since they're at an increased risk for bleeding, they're at risk for that. The neutropenic patient, we want to monitor for signs of infection. They don't have that immune system that can fight bacteria and viruses that enter their body. So we want to have them monitor for any fever, chills, sweat, shortness of breath, anything that just indicates an infection. Neutropenic precautions is a very, very important point with these patients receiving chemotherapy. When they go into the hospital, we'll put them on neutropenic precautions. So that includes monitoring for spikes in temperature. Most patients today are in private rooms, but make sure that they're in a private room. With COVID, we're wearing masks already, but hopefully once we get out of this and we don't have to wear masks, wear a mask in those patients' rooms. One thing that is frequently tested on with neutropenic precautions is no fresh fruits or veggies, no live flowers. Make sure that meat is thoroughly cooked. And that is because all of these are things that viruses and bacteria can live on. So they can bring that into the room with the patient and infect the patient. So really anything we can do to keep that extra viruses, bacteria out of the patient's environment. Additional considerations are that we want to maximize their physical functioning, along with the side effects of chemotherapy. The patient is already tired because of their anemia. So frequent wet rest periods, let the patient listen to their body. We want to provide pain control as needed. Talk to them about their goals of care. What are they expecting to get out of treatment? Is it even realistic? And just help to establish some realistic goals of care with them. We want to provide psychological support because leukemia is cancer. It's a devastating diagnosis for most people. So we want to include their family in discussions in the plan of care and in the education. So once again with the education, we do want to talk to them about signs and symptoms of infection, when to call their doctor, and the increased risk of bleeding, that kind of thing. So we'll jump into our first case study here. If you want to answer, just answer out loud. No need to raise your hand or anything. Okay, so SR is a 68-year-old male diagnosed with AML. He's currently receiving chemotherapy with his most recent treatment 3 days ago. He presents to the hospital with increased weakness, headache, and a fever of 102 degrees. So what are some common side effects of chemotherapy that you would consider when caring for SR?
Fever.
Okay, fever.
Increases for infection.
And then what about in their oral cavities or
mouth sores?
Okay. How about appetite or their bowel habits?
Decreased appetite.
Diarrhea, constipation.
Yeah. So they have those mouth sores, loss of appetite, nausea, vomiting, diarrhea, constipation. They will have alterations in their blood cell counts, could have weight loss, fatigue and weakness, and impotence. So all of that could play a part in his care. When looking at SR's labs, would you expect his white blood cell count to be high or low, and why?
Low. Very low.
Why would it be low?
Decreases the immune system.
So he has leukemia. We know that he's also receiving chemotherapy. The chemotherapy will knock out all of your abnormal white blood cells as well as all of your normal ones. So the patient will have a low white blood cell count due to that. Last question, given SR's low white blood cell count, what nursing interventions would you implement?
Neutropenic precautions.
Neutropenic precautions. What are a few things that go into that?
Masks. No live flowers.
Yeah?
Meat well cooked.
Private room.
Okay.
Private room. No visitors.
Wash your hands.
No sick visitors. Limited time.
Wash your hands. That's one that I did not mention. That
We should do
But,
it.
yeah. All right, good job. So that's the end of leukemia. Do you guys have any questions about that before we move on? No? Okay. So moving on to sickle cell. What is sickle cell disease? It is an autosomal recessive disorder. I even included a little Punnett square here for y'all. Bringing back to biology. So let's just say that this big S here is a normal cell. This little s is a sickle cell gene. So in this case, both of the parents are carriers for sickle cell. If they do have a child, then that child has a 25% chance of getting sickle cell, which is represented by these two little red S's here. If these parents have a child, they also have a 50% chance of having one that is a carrier. Now, carriers for sickle cell, since it is a recessive disorder, they don't display any symptoms of the disease, but they can pass it along to their children. Does that make sense? Yeah. Okay. So with sickle cell, the red blood cells become hard and sticky. They form a C shape, which is called a sickle, which is how it gets its name. These sickle cells die early, which causes a shortage of red blood cells. It can often be found during neonatal screening and even before birth. So this is a disease that children are born with. They can display symptoms as early as 5 months old. So about 1 out of every 365 African American births are affected by sickle cell, and about 1 in every 16,300 Hispanic American births are affected. So this is primarily a disease of people of sub-Saharan African, South Asian, Middle Eastern, and Mediterranean descent. And just another statistic, about 1 in every 13 African American babies are born with the sickle cell trait. So this is just a video, real quick, kind of showing what those cells look like and what they do in the blood. If it had volume. Let's see if I can get this to work real quick.
In people with sickle cell disease, their red blood cells become deformed, turning sickle-shaped. The bone marrow tries to make more red cells to make up for the loss, but can't keep up, causing anemia. Their new shape keeps them from moving properly through the body, and the misshapen cells can jam up and stick to the walls of the blood vessels. These clumps cut off oxygen to healthy tissue, delaying a child's normal growth and causing fatigue and extreme pain.
Yeah, you can kind of see the shape of the cell, how they can clump up in the blood. So manifestations of sickle cell. Typically, patients that have sickle cell, they can be generally healthy. They're not always sick. They may have chronic disorders related to that tissue hypoxia, decreased blood to organs. So they are not always hurting, always in pain. That's just what we see in the hospital and what we think about. Typically, patients are anemic. This is asymptomatic normally until they have sickling episodes. So we want to think the sickled cells, like it said, your body's trying to make up for those red blood cells, but it's not producing enough. So these patients may walk around with a hemoglobin of 9 and they're fine. So we kind of want to reconsider that when we're looking at their labs, like, yes, 9 is low for a healthy individual, but with a patient with sickle cell, that's maybe their normal. And they may also have pallor, which with these patients, pallor, we can typically detect that by looking at their mucous membranes. They have jaundice, which we can look at their eyes and see that. With patients with darker skin tones, it might be a little bit harder to notice these changes in their skin. So just looking at their mucous membrane, their eyes, that can reveal a lot as well. During a crisis, the main manifestation is pain. So they can be in excruciating pain. This is because of that lack of oxygen, tissue hypoxia and ischemia that will lead to that excruciating pain. It may also be accompanied with fever, swelling, tachypnea, hypertension, and nausea and vomiting. There are several complications that go along with sickle cell. Infection is the major cause of morbidity and mortality in this group, and especially pneumonia. An aplastic crisis is another complication. So this causes a temporary shutdown of red blood cell production. So if you think back to that video, the body is trying to create more red blood cells, but in an aplastic crisis, there is a shutdown of this production. So they will be even more anemic than they already are. Acute chest syndrome, this is a very, very serious complication that can lead to death. It is a vaso-occlusion of the pulmonary vasculature. Signs and symptoms that we want to look out for are a new fever, new chest pain, cough, shortness of breath, and any new lung infiltrates. And with these next two, heart failure and renal failure, so we want to think about oxygen delivery in the blood. So the major organs that need oxygen delivery, such as your heart, your kidneys, your lungs, brain, that they are going to have decreased oxygen. So that can lead to failure and just poor function of these organs. They are also at an increased risk for pulmonary embolism or stroke because of these clots that are forming, and chronic leg ulcers because blood flow is impaired. Management of the patient with sickle cell is heavily focused on pain management. Patients will be on continuous opioid analgesics, and that will either be morphine or hydromorphone most of the time, and that will be in delivery of a PCA pump. They'll also have breakthrough analgesia, and typically this is ordered as like a bolus dose of that morphine or hydromorphone. The patient can also be treated with NSAIDs such as ibuprofen, anti-neuropathic pain drugs, so that's your anti-seizure drugs. They can also have local anesthetics or nerve blocks. Additional management that we want to consider is oxygen therapy. Initially and early on, sickling may be reversible with reoxygenation. So we want to keep a close eye on the patient's oxygen saturations, make sure that we're providing them with oxygen if they need it, and encouraging incentive spirometry. So that is another thing that we can do to help the patient take those deep breaths, increase their oxygen on their own. DVT prophylaxis to help prevent those blood clots. This can be done in the form of medications such as heparin or Lovenox, or the patient may have SCDs or tethoza. The patient will also be getting some gentle IV fluids. So IV fluids help to decrease the blood viscosity and maintain renal function. Hydroxyurea is a medication that a lot of patients will get. So this is known to increase the production of the hemoglobin F, and it alters the adhesion of sickled red blood cells to the endothelium. So essentially, this is given to help reduce the number of sickle cell crises that occur. With the aplastic crisis, so this is the decrease in red blood cell production. So these patients will commonly get blood transfusions, but it is important to point out that with sickle cell patients, we want to use blood transfusions sparingly. And this is because of the tendency to create antibodies and iron overload.
I have a question about the aplastic crisis.
Yeah.
How do you diagnose a patient with aplastic crisis? Like, is it just through a CBC or something like that?
I'm not
Is there-
100% certain
Okay.
on that, but that's what my assumption is.
Okay,
Part
because
of
if
it
they're
is
already
the CDC,
anemic.
you're looking at the CDC, you
Okay.
said rate, the said rate a lot
Okay,
in those patients.
and they'll just have like a lower than normal.
Lower than normal
Hemoglobin?
hemoglobin.
Okay.
And that
A
will
lot of
also be
times we don't
associated with,
transfuse
like-
them until they're less than 7.
Right, okay.
Could you also go off of their signs and symptoms too?
That would be a big indicator of if they actually are symptomatic, because typically if they have their normal hemoglobin, they're not. But then they might actually be symptomatic at that point.
So they're always, like, if someone has sickle cell, they might have a normal hemoglobin?
They more than likely will have a little bit lower than what like you or I have,
Right.
but their normal is different than our normal.
So if it's like way, way low? Gotcha.
So like Felicia said, typically we transfuse under 7,
Okay.
or if they're symptomatic. Alright, and then with acute chest syndrome, so this is an emergency. We'll start them on broad spectrum antibiotics. This is because acute chest syndrome can be caused by infection. So we want to start them on antibiotics to see if that could help knock out that infection. They'll also get the oxygen therapy and the fluid therapy. Additional considerations, so tolerance to pain medications can occur. These patients are on pain medications, and so it may take more and more and more to manage their pain. So something that may seem like a huge amount of pain medication to us is just enough for them to actually get their pain under control and help them feel more comfortable. So we may have to up their medications as time goes on. We also want to take a holistic approach to pain management. We talked about different types of pain medicines besides opioids. We also want to consider consulting an occupational therapist or a physical therapist to help maximize the patient's functioning. This could also teach them different methods of how to still live their life and without triggering any pain that they may be having. And we also want to provide them with heat therapy. A lot of patients will bring a heat pack of their own, or they can get one from the hospital and put it on those points that hurt the most. And we also want to remember that the pain that these patients have, typically a lot of patients will complain about it in their extremities, in their chest, in their back. So we just kind of want to help them mobilize as best as they can. And we want to provide psychological support for them. So this is a disease that they've had their whole life. They may have some feelings of depression, anxiety, anger about their diagnosis. So we want to be supportive to the patient, provide them with any resources that they may need. They may want to talk to a chaplain or talk to a psychologist. So just kind of be there, listen to them, and provide support for them. And genetic counseling is recommended for patients with sickle cell. And this goes back to that first slide with the Punnett square. So the patients, they can pass it on to their children, and those children can pass it on to the next generation, and it can go on and on. So it's important to counsel the patients about their chances of passing it on, so that they are fully aware that they can pass it on to their children, how likely it is, and that can also help them make any decisions as far as family planning. One of the most important things that we can do is to teach patients how to avoid a crisis. So a sickle cell crisis is often related, the most frequent cause of it is an infection. So we want the patient to get prompt treatment of their infections and to get their vaccinations, because we know that vaccinations can help to prevent infections. We also want to teach them to avoid high altitudes, so they can't go hiking in Colorado for hours on end, or situations with low oxygen levels. Maintain an adequate fluid intake so that they are hydrated. Try not to get too hot or too cold, so they may have to bring layers when they go somewhere and take their layers off, put some on, whatever it takes to help regulate their body temperature. Avoid strenuous exercise. So strenuous exercise causes more oxygen levels to be needed. And if they are, say, training for a marathon, they're going to require more oxygen, which they don't have. That can trigger a crisis. And to avoid alcohol or smoking, because we know that alcohol can lead to dehydration and smoking is vasoconstricting. That brings us to our next case study. ST is a 27-year-old female hospitalized for sickle cell pain crisis. She is complaining of 10 out of 10 pain and asking for her PR and pain medication. She also states that her meal tray never arrived and is asking for snacks from the nutrition room. When you enter her room, you note that her oxygen saturation is 86% on room air. Which of ST's needs would you attend to first and why?
Oxygen.
Mm-hmm. Why would you do that first?
You don't want her oxygen to drop too low because, you don't want her to become ischemic.
Just like you said, so you would attend to her oxygen saturation first. because hypoxia can lead to deoxygenation of the red blood cells and therefore more sickling. And that's just kind of a domino effect. More sickling can lead to further restriction of blood flow, which can lead to thrombi, tissue ischemia, infarction, and necrosis. We place her on 2 liters of nasal cannula and her oxygen increases to 96%. Which need do you address next?
Pain.
Pain. We administer her PRN pain medication and implement any holistic approaches. Do you have any questions about that material or anything that we thought of from leukemia? No? Okay, we're gonna play Jeopardy. So you guys split up into 2 even teams. Straight down the middle if you want.
Straight down the middle?
Yeah.
Alright. So what we'll do with this, you guys, have you guys all seen Jeopardy?
Mm-hmm.
Okay.
Yeah.
So 2 even teams will rock, paper, scissors to see who goes first. If you know the answer, first one I see to raise their hand will be the one to answer it, and you'll get the point for your team if you get it right. So who wants to rock, paper, scissors?
I guess.
Alright, so you guys will be team 1 and team 2.
Okay.
Alright, team 1. What would you
I'm gonna have to
like?
do the hand raising.
Sorry.
It's okay. Outline? Okay.
Come on now.
These are the 4 main types of leukemia.
Yes. Okay.
2.
Acute lymphatic. Wait. Yes. Acute myelogenous
I
leukemia.
should have a timer. You can't use your notes.
I still know it.
Okay.
AML,
LLCLLCML.
Yep.
Good job. Point to
Good job. I just put it into my draws.
team 2. All right, team 2, so you get the next pick.
Go for it.
Treatment and management 300.
Okay. Targeted blank may be used along with chemotherapy in the treatment of leukemia. I don't know who has the all first. Hannah.
Radiation.
That's what I was gonna say.
Correct.
Do I have to say what it is?
Oh, yeah.
What is that?
All right, team 1.
Let's do clinical manifestations 400.
Okay. Palpating the neck and armpits of a patient with leukemia.
That's easy.
Feel swollen leg. Okay, team 2, I saw you first.
Lymph
Lymph
nodes.
nodes.
Correct.
I want to be in your class.
Yeah, I know, right?
All right, team 2.
Go ahead.
Let's do leukemia considerations for 500.
In the patient with leukemia, temperature should not be taken by this route.
Yeah.
Team 1.
Back to win.
Not oral. Did you say what?
Rectal.
Good job.
Yeah,
That's something I totally forgot to talk about. So great job.
She said it to me!
she said oral.
Bleeding in on my way down
I heard Hannah whisper rectal. I'll give you the point. All right, team 1.
You said that first and then you changed your mind. Alright, what are you gonna do?
I only got by 100.
I know, we gotta get this one.
Treatment and management for 5 or 6? Okay. These types of precautions should be implemented for the patient with leukemia. Team 2.
Don't read that fast.
So, neutropenic precautions.
Correct. All right, team 2.
You go ahead.
Sickle cell considerations 400.
This is the most common infection associated with sickle cell disease.
Pneumonia.
Dang it.
Very fast. Okay, team 1.
Let's do manifestations for 5.
Examination of a sickle cell patient's mucous membranes may reveal. Team 2.
Mouth sores.
Oh.
Oh,
Well, in dark patients.
Oh, yeah.
It would be parlor, right?
Correct.
You scared me for a
I
second.
know, I didn't know the question. I thought we were talking about leukemia. My turn? Okay. Patho 400.
In sickle cell disease, red blood cells form a sickle shape in response to low
Oxygen level.
oxygen levels. All right, team 1.
Sickle cell considerations for 3.
Blood transfusions are done sparingly in the patient with sickle cell due to the development of blank to red blood cells.
Antibodies.
That was good.
Antibodies. Close one.
Oh. Okay.
5.
Oh.
All right, team 1.
Treatment. 400.
Treatment for 400.
Yes.
This class of medications, such as ibuprofen, are
Incident.
used as adjunctive measures in the management of sickle cell disease. Team 1.
Dadgummit. All right,
We gotta pick it
get
up
the
here.
next, like 3 right.
All right, team 1.
Leukemia considerations for 4.
Okay, now we're on leukemia.
Okay.
The patient with leukemia should be instructed to be careful while shaving due to low
Platelet. Oh.
Okay, we did put our.
What?
White blood cells.
No.
I don't think so.
No.
Okay, so it's us now, right? Okay, so.
Due to low,
due to
RBCs.
blank or low platelet counts.
Okay, I read it wrong.
Shaving, we're talking about
Don't
hemoglobin.
say
no.
Nobody gets it.
Due to
Felicia,
While
you say
shaving.
it.
bleeding.
Due
Oh,
to.
I was thinking.
Also
Oh.
known as or platelet count.
Oh, yeah, that one is what.
That threw me off.
That threw me
You need
I
your
was
own
confused.
category.
All right, we'll let team 2 pick this.
You pick.
Sickle cell considerations 500, so you can get this right.
Okay, let's do it.
The patient with sickle cell should be taught to avoid sudden changes in temperature, which can cause this complication.
The sickle cell crisis.
Correct. All right, team 2.
Oh. Clinical manifestations for 300.
The patient with leukemia may present with fatigue, weakness, and shortness of breath due to low blank levels.
Low oxygen levels.
Well,
White blood cell.
Hemoglobin.
You only get one choice.
okay.
All right,
Hemoglobin.
team 1.
You already said oxygen. Hemoglobin.
It is hemoglobin.
What?
I'm
He
like,
said-
I'm so confused.
Me too.
Patho for 3.
Oh, wait.
Sickle cell disease is an autosomal blank disorder.
Genetic.
Genetic, you said?
Recessive.
Yeah, I said genetic.
Recessive.
It is recessive.
Okay. Good thing we have it.
Make it 2 answers?
No, it was my final answer, Hannah.
It is genetic, though.
Okay.
It's genetic, isn't it? Okay.
Keep it close.
Okay.
2.
Leukemia considerations are 300.
The patient on chemotherapy should incorporate foods high in blank and calories due to side effects of weight loss and anorexia. I saw team 1 first.
Protein.
Protein it is.
What is protein?
All right.
All right, Lace, we got to pick it up here.
Team 1.
We want
Huh? No, it's a
sickle cell for 2.
Nasal cannula and systemic spirometry are strategies to increase blank in patients with sickle cell degrees. Team 2.
oxygen.
Oxygen.
Oh, yeah.
There you go.
You want to do patho?
Yes.
Patho 200.
Leukemia is most often a cancer of this type of cell. Team 1.
White blood cell.
I know, what's that sentence?
Treatment and management 2.
Treatment for sickle cell disease usually includes continuous doses of this type of medication, team 2.
What?
Opioids, right?
Yeah. Like Dilaudid and morphine.
Opioids. Alright, try it up again, team 2.
You can put.
Let's go with clinical manifestations 100.
The patient with leukemia may present with elevated blink when checking vital signs. Team 1.
Temperature.
Temperature.
I knew it. I knew it, but I hesitated. That's why we get 100. Because now they're only 100 above us. So it's
Okay,
200.
that's good.
We'll do leukemia for 2.
This type of leukemia requires aggressive, timely treatment. Team 1.
Acute.
Acute.
Alright, Lace, we gotta pick it up
We can
here.
get this next one. We can get this next one.
Okay.
This is the primary symptom associated with sickle cell crisis. Team 2.
Pain.
Yep.
Let's go.
Okay, now we gotta get the next one right.
Okay,
Treatment and management?
that's fine.
Treatment and management.
This is the mainstay of leukemia treatment.
Yeah,
Chemo.
Oh.
Chemotherapy.
Okay, next two.
Just like shoot up your hand and we'll figure it out.
Disease onset for chronic leukemias
It's slow and gradual.
correct.
I'll do hand raising. Patho.
This disease is characterized by an abnormal form of hemoglobin in the red blood cells. I saw your answer.
Sickles. Yeah, sickles. Sickles
Sickle
level.
cell disease.
All right, let's go. Let's go.
I'm gonna need your help.
Let's go quick.
Alright. This is the major cause of morbidity and mortality in patients with sickle cell. I think it was team 2.
No!
Okay.
Is that what you saw?
Is it infection, right? Infection?
And
Woo!
Hey, good game, guys.
I just want you to know that we raised our hands faster than you. Okay?
If you think so.
Alright, so that was our Jeopardy game. What did y'all think?
It was good.
That was so fun.
Good.
Is there anything that you had questions about on that I might not have explained fully?
I think the hand raising facts enough. Yeah. You should work on that.
I'll remember that for next time.
Buzzers.
Yes.
Next time, we'll go all out. Alright, so this is just a QR code that y'all can scan. It's just like a 3-question survey to let me know how I did, what I could improve, just because this is what I'm doing with my life. So, just to help me.
I see you press code.
Uh-oh.
Overhead.
She's gonna wander that way and see what happens.
Alright. Well then that's everything. Thank you guys for participating.
Thank you.